you can disrupt the itch scratch cycle at a number of different avenues. So we have now had the development of multiple biologic and small molecule inhibitors that are able to rapidly reduce itch. And these inhibitors started with dupilumab, approved in 2017, an IL-4 receptor alpha inhibitor, and also has recently progressed to IL-13 antibodies like tralokinumab, lebrikizumab, which is more potent for the IL-13, and then recently nemolizumab, which is very potent for IL-31 inhibition, and also JAK1, which is a really important itch mediator. And so what we know is that itch pathogenesis traverses both the immune system and also the neural system. And so all of these targets are very safe. They're targeted, safer than traditional systemic immunosuppressants, but they're able to block both immune hyperresponsiveness and inflammation, but then also neural activity on the nerves. And many of these nerves, so they come from the skin. There's thinly mounted A delta fibers and unmyelinated C fibers. They go to the dorsal root ganglion, the spinal cord, and the brain. And so there's actually receptors in the dorsal root ganglion and the skin, and you're able to both block inflammation and itch. So that's been really just a tremendous breakthrough for our understanding of itch pathophysiology. I think the second biggest breakthrough that we're understanding is that itch can be very heterogeneous. So classically, the most difficult form of itch is itch without a rash. And what we know now is itch without a rash can actually be a result of the immune system being revved up. And our group recently published on blood TARC levels, IgE, eosinophils, type 2 inflammatory cytokines that are up in subsets of those patients. But there's also some patients who have actually have generalized neuropathic itch. And so we're really at the beginning of understanding these biomarkers and ways to endotype these different forms of itch, but we know that not all itches are created equal. So how people scratch can be different. You can scratch with a certain amplitude that creates a prurigo nodule, or you can scratch in a certain way that can have normal appearing skin. And our group actually did the first genetic studies of a condition called prurigo nodularis, where you get these itchy skin lesions, and found that you're actually genetically predisposed to have the lesions and have prurigo nodularis, or to have just generalized itch. And so both of those populations you need a workup. So I think we're better understanding the different phenotypes of itch now as well. And I think that many forms of itch involve both immune and neural involvement. And the immune involvement, we know in the bloodstream and the skin, many of these cytokines, IL-4, 13, 31, 22, JAK are all important for that. But that these same cytokine receptors are on the nerve ending. So I think that we understand the neuroimmune landscape of chronic itch. What we are also learning more about is that you can actually have direct damage to these somatosensory nerves in the somatosensory nervous system that then creates a different form of itch, neuropathic itch, that doesn't respond to any of these immune cytokine therapies. So certainly understanding the role of the nervous system and modulation of neuroimmunity as helping and being involved, but then also recognizing there's also direct damage to the somatosensory nervous system as well for a form of itch.